You step into the trauma bay, and the noise just hits you first.
Oh, yeah. It's never just the physical noise, right?
Exactly. I mean, sure, the monitors are alarming, the vents are cycling, the trauma chief is, barking orders, but it's the cognitive noise.
The mental overload is real.
Right. So picture this. A patient is rolling in, mechanism is a high-speed MVC, and the medics are shouting vitals that are, quite frankly, essentially incompatible with prolonged life.
Which is just a terrifying baseline.
Totally. We're talking a heart rate of like 140, a systolic blood pressure hovering maybe around 60, and a rigid, grossly distended abdomen.
So they are deep, deep into class 4 hemorrhagic shock.
Deep in it. The lethal triad of hypothermia, acidosis, and coagulopathy, it's already setting in. And intrinsically, you just know that the standard algorithms are about to fail.
Yeah, because dumping volume at that point is just, it's buying you seconds, not even minutes, seconds.
Exactly. You are standing at the absolute precipice of a preventable mortality, literally watching a life drain out into the retroperitoneum.
And that right there, that is the defining crucible of trauma surgery. You've got a patient with massive non-compressible torso hemorrhage.
Right, you can't just slap a tourniquet on it.
Exactly. You can't tourniquet a shattered pelvis or, an avulsed mesenteric root. The systemic perfusion is just collapsing. The heart is pumping against a totally empty tank, and the brain is starving.
And in that exact moment, the traditional maneuvers feel just agonizingly inadequate.
They really do.
Welcome to The Critical Edge, the no-nonsense podcast, breaking down the latest game-changing evidence in trauma and surgical critical care to give you the edge when things get critical.
Glad to be here for this one.
So in this deep dive, we are unpacking the reality, the physics, and the honestly heavily contested clinical data surrounding Reboa. That's resuscitative endovascular balloon occlusion of the aorta.
It's a mouthful, but it's changing everything.
It really is. We are moving way past the basic what is it and diving deep into the physiological mechanisms, the device engineering, and the highly debated literature that is currently dividing trauma centers all across the United States.
Yeah, and to really grasp this, we have to look at this intervention through the lens of, well, pure outcomes and brutal statistics.
Lay it on us.
So when you examine the epidemiological data, traumatic injury accounts for over 5 million deaths globally every single year.
Wow. 5 million.
Yeah. But when we look specifically at our domestic data, like from the American College of Surgeons and the CDC, the impact is even more devastating.
Right, because injury skews young.
Exactly. For years, injury has consistently outpaced, malignant neoplasms and heart disease in terms of years of potential life lost prior to age 70.
And the mechanism driving that mortality overwhelmingly is hemorrhage. We know that uncontrolled bleeding is responsible for about 40% of all trauma deaths.
But there's a worse stat.
Right. The statistic that should literally keep every surgical intensivist awake at night is that hemorrhage accounts for more than 80% of all trauma deaths that occur inside the operating room.
Let that sink in. 80%.
Right. That means these patients survived the field, they survived the transport, they survived your primary survey in the bay, they made it to your OR table, and they still exsanguinated.
And that, unfortunately, is the absolute definition of a potentially preventable death.
Yeah.
When you have severe subdiaphragmatic trauma, we're talking blunt abdominal crush injuries, open book pelvic fractures, massive retroperitoneal hematomas. The historical options were incredibly blunt instruments.
Oh, totally. We relied heavily on the resuscitative thoracotomy with descending aortic cross-clamping.
Which is just brutal.
It is. Let's be intellectually honest about the resuscitative thoracotomy in the setting of blunt subdiaphragmatic trauma. It is an act of sheer desperation.
It's a Hail Mary.
Right. You are inflicting massive surgical trauma. You're doing a clamshell or an anterolateral incision, literally spreading the ribs, physically mobilizing the lung, trying to find the aorta in a pool of blood, and slapping a DeVicki clamp on it.
Just to secure proximal control.
Exactly. And sure, for penetrating thoracic trauma, it has a documented role. But for blunt abdominal and pelvic hemorrhage, the survival rates are just abysmal.
Yeah, it's often considered feudal care in many modern level 1 centers now. The physiologic insult of the thoracotomy, combined with the existing profound hemorrhagic shock, is just a fatal combination.
Right. The patient just can't take the second hit.
Exactly. So the alternative historically was angioembolization. Take the patient to the IR suite, cannulate the vessel, shoot the dye, identify the extravasation, and embolize it.
But angio fundamentally ignores the reality of time.
Totally ignores it.
You cannot take a patient with a systolic of 50 to the IR suite. The time required to just mobilize the interventional team, prep the groin, get access, and navigate that selective catheterization. I mean, that's roughly an hour under the absolute best circumstance.
Best case scenario, yeah.
And a patient in extremis does not have an hour. They don't have 10 minutes. So we were left with this massive, terrifying therapeutic void between the futility of the cross-clamp and the agonizing delay of the IR suite.
Which brings us to the theoretical elegance of Reboa. Okay, let's unpack this.
Yeah.
Because it's crucial to understand that we are not actually discussing a novel concept here.
We aren't.
No, we are discussing a novel application of an old concept, which was made possible entirely by the evolution of endovascular engineering.
Right. To understand where we are, we have to look backward.
Right.
Why is a supposedly new technology actually rooted in a 70-year-old war?
Yeah, it's wild. It goes all the way back to the Korean conflict.
I always find it fascinating how wartime necessity just supercharges surgical innovation.
It really does. So in 1954, there was this military surgeon named Hughes. He was stationed in a forward surgical hospital, and he was watching these young soldiers bleed to death from massive lower extremity and pelvic junctional wounds.
Awful.
And he theorized that, hey, instead of cracking the chest to clamp the aorta from the outside, what if he could occlude it from the inside using a balloon catheter?
Physiologically, I mean, Hughes was an absolute visionary.
Ahead of his time.
He understood that proximal control was the only way to salvage the cardiac and cerebral perfusion pressure while simultaneously halting that distal exsanguination.
But technologically, he was operating in the dark ages.
Right, the gear just wasn't there.
Exactly. He actually attempted this intra-aortic balloon occlusion on 2 critically injured combat casualties.
And
both patients died.
yeah. And because of that dual mortality, the surgical community basically just shelved the concept for decades.
Just threw it in a drawer.
But the failure wasn't physiological, right? It was purely mechanical. They
Yeah.
didn't have the hydrophilic guide wires, the low-profile sheaths, or the compliant balloon polymers that we have today.
Not even close. They were trying to perform highly complex endovascular maneuvers with rudimentary, stiff tools on patients who were already profoundly coagulopathic.
It was doomed to fail. And, you know, medicine frequently abandons structurally sound ideas simply because the complementary technology hasn't caught up yet.
Happens all the time.
Right. It took 2 decades of rapid, explosive advancement in interventional cardiology and vascular surgery in the 80s and 90s to change things.
Yeah, all the development of robust stents, percutaneous transluminal angioplasty, sophisticated fluoroscopy.
All of that provided the hardware necessary to finally make Hughes's vision a survivable reality today.
Yeah. And if we connect this to the bigger picture, preserving that cerebral and cardiac perfusion while stopping distal hemorrhage is just the ultimate tightrope walk in trauma care.
It is. Let's visualize the hemodynamics of what we're actually doing here. Think of it like a massive plumbing issue, or better yet, a municipal hydraulic grid.
Okay, I like that.
Imagine the main aqueduct ruptures in the industrial district. Millions of gallons are just pouring out, dropping the water pressure for the entire city.
Disaster.
Right. You don't send a guy with a wrench to the industrial district and try and take up the specific pipe while it's actively exploding.
You'd never fix it in time.
Exactly. You run to the central dam and you shut the massive floodgates. Now, sure, the industrial district and the agricultural zones suffer a sudden catastrophic drought.
Which is the ischemia.
Right.
Yeah.
But you preserve the water pressure for the downtown core, the hospitals, the command centers.
That captures the systemic trade-off perfectly. By inflating that compliant balloon in the aorta, you are slamming shut the floodgates.
Boom, bleeding stops.
You instantly arrest the non-compressible torso hemorrhage distal to the balloon, but simultaneously, you are creating an intense, immediate augmentation of afterload for the left ventricle.
Because the blood has nowhere else to go.
Exactly. By blocking the downward flow, you force the entirety of the remaining circulating volume, plus whatever blood products you are rapidly infusing directly up into the carotid and coronary arteries.
We're taking a patient who is literally seconds away from hypoperfusion-induced cardiac arrest, and we are artificially, aggressively restoring their cerebral and myocardial perfusion.
It's incredible.
But if the concept is shutting off the main valve, how exactly do we safely navigate the human body's most critical pipe?
Very carefully. You can't just shove a balloon up there and inflate it indiscriminately. We have to map the aorta And the surgical community has codified this into 3 distinct deployment zones.
And mastery of these zones is absolutely non-negotiable, right?
100%. If you inflate in the wrong zone, you are not just failing to save the patient. You are actively iatrogenically ensuring their death.
Which is terrifying.
So let's break down the anatomy. Zone 1 is the descending thoracic aorta. It begins just distal to the origin of the left subclavian artery and extends down to the celiac trunk.
For the trauma surgeon standing at the bedside without fluoroscopy immediately available, we're looking at external landmarks.
Right, the tape measure method.
Exactly. Proximal zone 1 correlates roughly with the sternal notch, and distal zone 1 correlates with the xiphoid process. And zone 1 is the workhorse.
That's where you go for massive intra-abdominal hemorrhage.
Right. You inflate here, you occlude blood flow before it reaches the celiac trunk, the SMA, the renal arteries. You are clamping the entire abdomen and pelvis.
Then we have zone 3. This is the distal abdominal aorta extending from the lowest renal artery down to the aortic bifurcation.
So lower down.
Yep. Externally, we're looking at the area just above the umbilicus. We utilize zone 3 specifically for isolated catastrophic pelvic fractures.
Got it.
If you have a hemodynamically unstable open book pelvis, but your FAST exam is entirely negative for intraperitoneal free fluid, meaning the belly is dry, you don't want to subject the liver, spleen, and kidneys to unnecessary ischemia.
Makes sense.
So you advance the balloon to zone 3 and inflate, selectively isolating just the pelvic vascular bed.
Okay, so zone 1 is for the abdomen, zone 3 is for the isolated pelvis, but the critical gap in that geography is zone 2.
Ah, zone 2, the no-go zone.
The danger area. Zone 2 spans from the celiac trunk down to the lowest renal artery. From a deployment standpoint, zone 2 is strictly forbidden.
Absolutely contraindicated.
Why is this specific tiny segment so lethal?
Because zone 2 is the visceral command center. Within that very short segment of the aorta, you have the origins of the celiac trunk supplying the liver and stomach, the superior mesenteric artery, the SMA supplying the entire small bowel and proximal colon, and the bilateral renal arteries.
Okay, so if you inflate a high-pressure balloon right in the middle of that incredibly dense vascular real estate,
The mechanical forces are disastrous. First of all, you run a massive risk of directly tearing or physically occluding the ostia of these critical vessels.
just ripping them up.
Yeah. But more importantly, because of the proximity of these branches, a balloon in zone 2 is guaranteed to cause immediate, profound ischemia to multiple vital organ systems simultaneously.
It's a wipeout.
Total wipeout. You will induce massive small bowel necrosis, acute hepatic failure, and bilateral renal infarction. There is almost no clinical scenario where the patient survives the reperfusion injury associated with zone 2 occlusion.
I have to challenge the practical reality of this, though.
Go for it.
You're talking about millimeter-level precision regarding the celiac trunk and the renal arteries. But we are doing this in a chaotic trauma bay, right?
Very chaotic.
On a patient whose anatomy might be distorted by severe crush trauma, who is fully draped, and whose pulse is thready or totally absent? If their blood pressure is crashing below 70, how do you know exactly where the balloon is?
It's a great
Are
question.
you just guessing? Because the blind insertion based on external measurements feels a bit like Russian roulette.
You are absolutely right to push back on blind insertion. While we do teach the external landmark measurements, physically measuring the catheter against the patient's chest prior to insertion blind inflation is a last resort.
It has to be.
The standard of care demands radiographic confirmation whenever technically feasible.
And this is where the institutional infrastructure becomes incredibly critical.
Precisely. We rely heavily on real-time imaging. In highly resourced Level 1 centers, like the model developed at the University of Maryland or the University of Florida, the trauma day itself is a hybrid operating room.
Which is amazing.
It's game-changing. You have a fixed robotic C-arm fluoroscopy unit that can instantly swing over the patient. You gain femoral access, advance the catheter, and under live fluoroscopy, you can visualize the radiopaque markers on the balloon relative to the thoracic spine.
So you know exactly where you are.
Exactly. You confirm absolute zone 1 placement before you inject a single cc of saline into that balloon.
But if you don't have a hybrid OR, which a lot of places don't, you are utilizing a stat portable anteroposterior chest X-ray.
Yeah.
Or increasingly, we are seeing the utilization of transesophageal echocardiography, or TE, right in the trauma bay.
T is fantastic for this.
Right. A trained operator can drop a T probe, visualize the descending thoracic aorta, physically see the balloon catheter enter the field of view,
Yeah.
and confirm inflation in real time without using any radiation.
What's fascinating here is that the imaging isn't just to confirm where the balloon is, it's to confirm whether the balloon should be used at all.
Oh, that is a huge point.
The entire Reboa algorithm hinges on the absolute exclusion of thoracic hemorrhage.
Right. Let's dig into that hemodynamic nightmare. You have an unstable patient, and you suspect subdiaphragmatic bleeding. You do your primary survey. Why is a rapid chest x-ray or an EFAST exam to look for a hemothorax an absolute prerequisite before you even advance that wire?
It goes right back to your municipal hydraulic grid analogy. When you inflate the Reboa balloon in zone 1, you are drastically increasing the pressure proximal to the occlusion.
You're clamping the hose.
Exactly. You are significantly augmenting the systolic blood pressure in the aortic arch, the ascending aorta, and the pulmonary vasculature.
So, if there is an undiagnosed blunt aortic injury, like a partial tear in the descending aorta from a deceleration mechanism or a massive pulmonary laceration,
You will turn a survivable injury into an immediately fatal one.
wow.
By supercharging the proximal blood pressure, you will violently force blood out of that existing thoracic defect. A slow intrathoracic bleed instantly becomes a catastrophic, high-pressure exsanguination.
The patient will just rapidly tamponade or bleed out into their pleural cavity.
Exactly. That is why ruling out significant supradiaphragmatic trauma is step 1. If they have a massive hemothorax, Reboa is out, period. They need an immediate resuscitative thoracotomy.
It requires an incredible synthesis of diagnostic data in literally a matter of seconds.
It's the ultimate cognitive test.
So placing a balloon in the aorta sounds incredibly invasive. How has the actual hardware evolved to make this possible in an emergency room?
Oh, the physical evolution of this device is the only reason it transitioned from a niche vascular procedure to a frontline trauma intervention.
Because the old stuff was rough.
Yeah, it was. The early days of Reboa, roughly a decade ago, were defined by using off-the-shelf vascular surgery equipment. We were borrowing tools literally designed for elective aortic aneurysm repairs.
Which is crazy in a trauma setting.
Right. The standard setup required a 12 French introducer sheath and a 10 French compliant balloon, specifically the CODA balloon catheter.
Okay, let's contextualize what a 12 French sheath actually means for a trauma surgeon. In the French scale, 3 French equals 1 millimeter.
Yep.
So a 12 French sheath is a 4 millimeter outer diameter plastic pipe.
It's huge. And placing a 4-millimeter pipe into the common femoral artery of a patient in profound hemorrhagic shock is incredibly difficult.
There's no pressure.
Exactly. Because they are in shock, their peripheral vasculature is maximally clamped down, the femoral artery is spasming, and it's tiny.
So you couldn't just use a standard percutaneous Seldinger technique for that.
Nope.
The early literature describes the absolute necessity of an open femoral cutdown. You literally take a scalpel, make a vertical incision in the groin, dissect down through the subcu tissue, isolate the common femoral artery with vessel loops, and perform an open arteriotomy just to wedge the sheath in.
It's a formal surgical exposure, taking up precious time.
Right.
And the complexity didn't stop there. To get that 10 French CODA balloon up into the aorta, you had to navigate a 260-centimeter incredibly stiff Amplatz guide wire.
260 centimeters. That is over 8 feet of stiff wire.
Whipping around the room.
Managing an 8-foot wire in a cramped trauma bay, trying to ensure it remains sterile while multiple other teams are simultaneously working on the airway and the chest, that is an ergonomic nightmare.
Oh, but the real nightmare was removing the device.
Right, getting it out.
When you finally achieve hemorrhage control and you are ready to remove a 12 French sheath from an artery, you cannot simply hold manual pressure.
The hole is too big.
The arteriotomy is massive. If you just pull it out, the patient will bleed to death from their groin.
So it mandated a formal vascular repair. The trauma surgeon had to sit down, under tension, and primary repair the common femoral artery using delicate 5-0 or 6-0 polypropylene suture.
Which is not what you want to be doing after a massive resuscitation.
Exactly. If the artery was too small or damaged, you might even need a vein patch angioplasty. Closing a fragile vasoconstricted artery with microsurgical sutures on a patient who has just barely survived massive trauma. I mean, that's a recipe for strictures, thrombosis, and eventually limb ischemia.
The morbidity associated with the access site alone was a huge barrier to widespread adoption. The trauma community quickly realized that if a Reboa was actually going to be practical, the profile of the device had to shrink dramatically.
Here's where it gets really interesting. This brings us to the technological leap. Okay. The 7 French ER Reboa catheter.
It changed everything.
It entirely changed the physics of the procedure. It's like dragging a heavy desktop computer into a trauma bay versus bringing a sleek wireless tablet.
That's a great way to look at it. The 7 French system, which is roughly 2.3 millimeters in diameter, eliminated almost all the logistical hurdles of the legacy system.
Because it's so much smaller.
First and foremost, a 7 French profile allows for true percutaneous access.
No more cut downs.
Exactly. We use standard ultrasound-guided percutaneous puncture. We visualize the common femoral artery, ensuring we are proximal to the bifurcation of the superficial femoral and profunda. Of course, access with a micropuncture needle, wire it, and slide the 7 French sheath directly in.
So much faster.
It is the exact same skill set required to place a central venous line or an arterial line, which every U.S.-trained general surgery resident masters in their intern year.
Furthermore, the 7 French Reboa eliminated that awful 8-foot stiff wire.
Thank goodness.
Right. It was designed with a built-in atraumatic J-tip, often called the P-tip, and an integrated nitinol backbone. It has enough columnar strength to just be advanced directly through the sheath and up the aorta without requiring any over-the-wire exchange technique.
It's essentially wireless. And critically, when the resuscitation is complete, you can simply pull the 7 French catheter and sheath out and just hold direct manual pressure on the groin for 10 to 15 minutes to achieve hemostasis.
That's it?
That's it. No open vascular repair, no 6-neuro-proline. It significantly reduced the incidence of access site pseudoaneurysms and arterial thrombosis.
But the tablet has a flaw, right?
Yeah.
Physics always demands a trade-off. We took away the 8-foot rigid stiff wire to make it easier and faster, but by removing that rigidity, we introduced a terrifying new hemodynamic problem inside the aorta.
Yeah, we have to talk about the phenomenon of distal migration.
Let's get into it.
When you inflate a balloon in zone 1, you are creating a massive pressure gradient. You have a high-pressure, hyperdynamic left ventricle pumping aggressively directly against the top dome of that balloon.
And what is holding the balloon in place against that immense systolic shear stress? Literally just a flexible 2.3 millimeter catheter shaft extending all the way down into the groin.
Exactly. The compliance of the 7 French catheter means it lacks the rigid longitudinal support of the old 12 French system.
So it bends.
Right. As the proximal blood pressure rebounds, which is exactly what we want to happen, obviously that systolic wave physically hammers against the balloon. The balloon acts like a parachute catching a gale force wind. It naturally wants to slide distally down the aorta.
And if it slides distally from zone 1?
It migrates directly into the forbidden zone 2.
Wow. So you think you save the patient, you walk away to scrub in for the exploratory laparotomy, and meanwhile the balloon has slipped down and is currently crushing the superior mesenteric artery, silently inducing complete bowel necrosis.
Which is why the protocol mandates relentless vigilance. You cannot just inflate and forget.
Never.
The catheter must be physically secured at the insertion site, usually with heavy sutures, and you require continuous periodic imaging, either serial, fluoro, or T, to confirm that the balloon has not migrated under the pressure of the resuscitated heart.
But even if the balloon stays perfectly in zone 1, there is a fundamental biological limit to what we are doing here.
A clock.
Right. This is where the engineering marvel hits the brick wall of human cellular physiology. We have to talk about the 60-minute ticking clock.
The 60-minute rule is the absolute non-negotiable threshold of Reboa. It is the defining limitation of the entire procedure.
Let's dive into the cellular mechanics of why that is. When we inflate the balloon in zone 1, we are intentionally inducing profound distal hypoperfusion.
We are starving the lower half.
The lower half of the body, the bowel, the kidneys, the liver, the skeletal muscle of the lower extremities, is suddenly totally cut off from oxygenated blood. What happens at the microscopic level, minute by minute?
Within minutes, the cells distal to the occlusion burn through their remaining oxygen reserves. They're forced to switch from aerobic respiration to anaerobic metabolism just to survive.
And anaerobic metabolism is incredibly inefficient and highly toxic.
Very. It produces a fraction of the ATP, the cellular energy currency, and generates massive amounts of lactic acid as a byproduct.
So the pH just drops.
Plummets. As the lactic acid accumulates, the local tissue pH drops completely. We are inducing a profound, localized metabolic acidosis.
And without adequate ATP, the fundamental cellular machinery begins to fail. The sodium-potassium ATPase pumps on the cell membranes just stop working.
Yep.
Sodium floods into the cells, pulling water with it. The cells literally swell and begin to releasing potassium and toxic intracellular enzymes right into the stagnant blood pool.
The clinical data is unequivocal here. If you leave a complete aortic occlusion in place for more than 60 minutes, the ischemic damage to the gut and the kidneys becomes irreversible.
Game over.
But the actual lethal event often doesn't occur during the occlusion, it occurs during the deflation.
Reperfusion injury. The washout phenomenon.
When the surgical team finally controls the bleeding in the abdomen and deflates the Reboa balloon, normal blood flow rushes back into that ischemic territory.
And it picks up all the garbage.
All of it. It flushes all of that accumulated lactic acid, the extracellular potassium, and this massive wave of reactive oxygen species and inflammatory cytokines directly back into the central venous circulation.
So that highly toxic, acidotic, hyperkalemic bolus hits the right atrium, travels to the lungs, and hits the myocardium.
And it frequently induces immediate refractory ventricular fibrillation or profound myocardial depression. The heart simply arrests.
Which is why the deflation must be meticulously coordinated with the anesthesia team.
Meticulously.
They have to be pushing bicarbonate, calcium, and massive volume at the exact moment you slowly, incrementally deflate the balloon to try and mitigate that systemic inflammatory washout.
60 minutes. From the moment the balloon goes up, you have less than an hour to secure the airway, push massive transfusion protocol blood products, transport the patient to the operating room, perform an exploratory laparotomy, identify the bleeding solid organ or vascular injury, achieve definitive surgical hemostasis, and begin deflating the balloon.
It's a sprint. A sleek wireless device that can slide out of place and kills the patient if left for 61 minutes requires incredible skill. How on earth do you train a massive rotating hospital staff to do this safely?
The training dilemma has been hotly debated. When Reboa first gained traction, we saw two extreme approaches, and the literature suggests both were pretty much failures.
What was the first?
The first extreme was the highly restrictive model. Institutions demanded that every single attending trauma surgeon attend a formal, multi-day external endovascular skills course, often involving live animal labs before they were credentialed to use the device.
I mean, from a medical legal standpoint, that sounds incredibly safe, but practically, that's a disaster.
Totally impractical.
Sending an entire roster of busy trauma surgeons out of state for multi-day courses is exorbitantly expensive and creates a multi-year bottleneck. The life-saving technology just sits on the shelf while people wait for a training slot.
Conversely, the other extreme was what we call the Wild West approach. Some centers simply purchased the 7 French catheters, stocked them in the trauma bay, and assumed that board-certified surgeons would just figure it out on the fly.
And the literature is clear that this is a catastrophic option. The text bluntly calls it not a viable option.
Yeah, you can't just wing it.
Dropping a highly nuanced device into a high-stress environment without formalized protocols leads to disastrous misdeployments, prolonged inflation times, and, frankly, preventable mortalities. You cannot wing it with aortic occlusion.
Exactly. The solution that emerged as the gold standard is the middle path, the institutional champion model, which was really pioneered by centers like the University of Florida.
I really marvel at the pragmatism of this approach. Instead of sending the entire department, the hospital designates one highly motivated trauma surgeon, the Reboa champion.
One person.
Right. That single individual attends the formal, comprehensive external training course. They master the endovascular techniques, the physics of the guide wires, and the complications.
Then that champion returns to the home institution and builds a customized internal training curriculum.
And what's remarkable is how streamlined this internal training actually is.
It's very tight.
The University of Florida model required only a 1.5-hour didactic slide presentation, followed by high-fidelity simulation and hands-on deliberate practice with the specific equipment for the trauma surgeons and senior residents.
Yeah.
I mean, an hour and a half of didactic seems shockingly brief for such a high-stakes procedure. But it makes sense when you consider the audience. We are not teaching them how to be surgeons.
No, they already know how to access vessels. The core competency required for the 7 French percutaneous Reboa is just the Seldinger technique.
Which they do every day.
Right. Every U.S.-trained general surgery resident has placed dozens, if not hundreds, of central venous catheters, arterial lines, or assisted in placing IVC filters.
So the manual dexterity, the ultrasound needle guidance, the tactile feedback of passing a wire, they already possess that muscle memory.
Exactly. The training doesn't need to teach them how to puncture a femoral artery. The gap isn't manual dexterity, it's understanding the specific RBOA algorithm.
So the 1.5-hour didactic focuses purely on the decision tree.
Yes. The absolute contraindications, the exact anatomical definitions of zones 1 and 3, the mechanics of the P-tip, the absolute necessity of radiographic confirmation, and obviously strict adherence to the 60-minute ischemic clock.
Furthermore, the champion model recognizes that Reboa is a team sport. It's not just about the surgeon.
No, it takes a village.
The champion also conducts 30-minute orientation sessions for the emergency department nurses, the OR scrub techs, and the anesthesia providers.
Crucial.
Because if the surgeon asks for the ER Reboa, the scrub tech needs to know exactly how to flush the catheter, and the anesthesiologist needs to start prepping the calcium and bicarb for the deflation washout.
The champion democratizes the knowledge efficiently. It's brilliant.
It's a masterclass in institutional knowledge transfer. So we have the history, we understand the anatomy and the slick new tech, and we have the training protocol.
Yeah.
So what does this all mean? Does this thing actually save lives when the rubber meets the road?
And this is where we step into the most highly contested battlefield in modern trauma surgery literature, the great data debate.
Miracle or mirage?
Exactly. The data surrounding Reboa survival outcomes is deeply polarized. We have highly respected, multi-center trials showing miraculous survival benefits, and then we have massive national database studies suggesting it actively harms patients.
So we need to dissect the methodology to understand why the numbers are clashing so violently. Let's start with the optimistic data.
Let's do it.
The early adopters published studies that essentially hailed Reboa as a paradigm shift. Let's look at the landmark 2015 study by Moore et al.
Moore and colleagues published a comparative analysis looking at patients undergoing Reboa versus the traditional resuscitative thoracotomy with cross-clamping for severe subdiaphragmatic hemorrhage.
And results.
The results were staggering. The Reboa cohort demonstrated a survival rate of 37.5% compared to an abysmal 9.5% survival rate in the thoracotomy cohort.
A nearly four-fold increase in survival.
Massive.
In the world of hemorrhagic shock, a 28% absolute risk reduction in mortality is unheard of. It felt like definitive proof.
And that data was corroborated by other prominent investigators. DuBose, utilizing data from the Aorta registry, which is a prospective observational registry of aortic occlusion, found similar outcomes.
What did they find?
They demonstrated a higher rate of overall survival for Reboa, 28% versus 16% for open occlusion. But critically, they also looked at hemodynamics.
Right.
They found that Reboa was significantly more effective at achieving hemodynamic stability, actually getting the blood pressure back into a perfusing range compared to opening the chest.
We also saw international data validating this trend. The Japanese have been very aggressive in adopting Reboa.
Very aggressive.
The nationwide cohort study out of Japan by Abe et al. Found that Reboa was associated with lower mortality and, unsurprisingly, drastically fewer thoracic complications.
Because you weren't cracking the chest.
Right. And a comprehensive meta-analysis by Nunez, which aggregated data from 13 different comparative studies, consistently pointed toward a mortality benefit for endovascular occlusion over open surgical occlusion.
Plus, studies like Northern proved it works even in austere combat environments.
So if we stop right there, the argument is over. Reboa is superior. It's less invasive, it restores hemodynamics better, and it yields higher survival rates.
But we can't stop there.
No, we can't. Because then we have to confront the bombshell study, the massive contradiction, the paper that caused trauma directors across the country to slam on the brakes.
Let's talk about the Joseph et al. Study utilizing the TQIP database.
The Joseph study is the primary source of the current academic whiplash.
It really is. The authors utilized the Trauma Quality Improvement Program, or TQIP, database.
Yeah.
TQIP is a massive, incredibly powerful national database maintained by the American College of Surgeons.
It captures data from hundreds of trauma centers across the U.S. Because it's a massive database, it allows for huge sample sizes, which obviously gives the study immense statistical power.
Right. To attempt to compare apples to apples, the researchers used a sophisticated statistical methodology called propensity score matching.
Which sounds good on paper.
It does. They took patients who received Reboa and mathematically matched them to patients who did not receive Reboa based on measurable variables like the injury severity score, the ISS age, mechanism of injury, and initial blood pressure.
And what were the results of this massive propensity-matched analysis?
They were devastating. Joseph et al. Found absolutely no difference in 4-hour or 24-hour packed red blood cell transfusion requirement.
No difference at all.
None. There was no difference in ICU length of stay or total hospital length of stay either.
I mean, finding no difference would be disappointing, but it was worse than that, wasn't it?
Far worse. They found that the patients who received Reboa actually had a statistically significant increase in overall mortality compared to the matched cohort.
Wow.
Furthermore, they found massively increased rates of severe complications, specifically acute kidney injury requiring dialysis and a significantly higher rate of lower extremity amputations.
Increased death, increased kidney failure, increased amputations. The paper essentially argued that Reboa wasn't just ineffective, it was iatrogenically harming patients.
Yeah.
How do we reconcile this? How can more Endovos show a quadrupling of survival while a massive ACS database shows increased mortality?
This raises an important question about how we evaluate emergency interventions. Comparing Reboa to a resuscitative thoracotomy might be fundamentally flawed.
Why?
Because the reconciliation lies in understanding the profound methodological limitations of retrospective database analysis in trauma surgery. We have to talk about unmeasured confounding and the most insidious enemy of clinical research: selection bias.
Selection bias. Let's critically evaluate the TQIP data through the lens of a practicing surgeon. Propensity score matching is only as good as the variables you can enter into the algorithm, right?
Exactly. TQIP relies on ICD and CPT coding and broad physiologic markers taken at specific snapshots in time, usually just upon ED arrival.
But trauma resuscitation is a dynamic, minute-by-minute physiological freefall.
It's not static. The database might show 2 patients who both arrived with a systolic blood pressure of 70 and an injury severity score of 45.
So the propensity score matches them. It says they are identical.
But the database cannot capture the eyeball test. It cannot capture the fact that patient A transiently responded to a unit of whole blood, while patient B completely lost their pulse 3 minutes after rolling through the door.
Ah, I see. The surgeon standing in the bay makes the split-second decision to deploy a Reboa precisely because patient B is dying faster.
Yes. They deploy it in extremis. Reboa is fundamentally reserved for the absolute sickest of the sick, the patients who are actively exsanguinating and totally unresponsive to volume.
And that is the crux of the selection bias. If you are exclusively using a highly invasive, high-risk intervention on patients who are already 99% likely to die, their mortality rates will inevitably look terrible.
Even if you try to statistically match them based on arrival vitals.
Right, because the TQIP database, despite its size, lacks the granular second-by-second physiologic resolution needed to capture the trajectory of the crash.
Exactly. As for the complications, the acute kidney injury and the amputations that actually validates the physiology we discussed earlier,
The 60-minute clock.
it perfectly aligns with the 60-minute ischemic clock. If you survive a massive hemorrhage because a Reboa kept your brain and heart perfused, you are now alive to experience the consequences of that 45-minute profound ischemic hit to your kidneys and your legs.
And the match cohort who didn't get Reboa.
They didn't get acute kidney injury because, frankly, many of them probably died of hemorrhagic shock before their kidneys had time to fail.
Survivor bias.
Yep. The dead don't get dialysis.
It's a grim reality, but it's statistically vital to acknowledge. This is why the debate is so fierce. We are comparing small, highly protocolized single-center studies against massive but blunt national registries.
And despite the sobering data from Joseph et al., institutions that have heavily invested in the infrastructure, the training, and the strict protocols like the University of Florida or Shock Trauma in Baltimore continue to report profound clinical successes.
Right, they're seeing decreased blood transfusions in their own prospective cohorts.
They argue that when deployed correctly, rapidly, and by highly trained operators, the device absolutely works.
So we exist in this tense clinical reality. The device is powerful, the risks are immense, and the data is conflicting. Where does this technology go from here? What is the bleeding edge of Reboa research?
The future of this technology is entirely focused on mitigating the devastating effects of that 60-minute ischemic clock. And the most promising avenue of research right now is a concept called variable partial inflation, or P-Reboa.
Partial Reboa. Mechanically, we are talking about moving away from a binary system. Right now, it's either fully inflated total occlusion, zero flow to the legs, or fully deflated.
Exactly. Complete occlusion guarantees maximum cerebral and coronary perfusion, but guarantees distal ischemia. The concept of Reboa is essentially finding the perfect physiological equilibrium.
How does that work?
Instead of fully occluding the aorta, what if we inflate the balloon just enough to provide life-saving proximal pressure, but leave it slightly deflated, just a fraction of a millimeter, to allow a tiny controlled trickle of blood to slip past the balloon.
So you are intentionally allowing a minor low-pressure flow to reach the visceral organs and the lower extremities.
The goal is to provide just enough distal perfusion to prevent the tissue from switching completely to anaerobic metabolism.
Which is huge.
If you can maintain a minimal flow, you drastically slow down the accumulation of lactic acid, you delay the onset of cellular swelling, and you mitigate that massive inflammatory reperfusion injury when you eventually deflate.
The literature suggests this is highly effective in porcine animal models. But honestly, the technical execution in the human trauma patient sounds impossibly delicate.
It's extremely difficult.
You are trying to manually titrate a balloon volume with a syringe to allow exactly, 200 cc's of flow past a moving target and a hyperdynamic aorta.
Manually, it is nearly impossible. The human hand cannot react fast enough to the changing pressure gradients. That is why the true future lies in automated, closed-loop computer algorithms.
Like a smart Reboa.
Exactly. We are looking at prototypes where the Reboa catheter is hooked up to a computerized pump that is constantly reading the patient's arterial line pressure.
Oh, wow.
The algorithm micro-adjusts the balloon volume millisecond by millisecond, ensuring the proximal pressure stays exactly at 80 millimeters of mercury while allowing maximum safe flow to the distal organs.
If they perfect that closed-loop Reboa, it theoretically shatters the 60-minute limit.
It could change everything.
If you can keep the organs alive with a trickle of blood, you might buy the surgical team 2 or 3 hours to definitively repair complex retroperitoneal injuries.
And as the technology becomes more refined, we are seeing the indications expand far beyond just the trauma bay. The application of Reboa for non-traumatic massive hemorrhage is rapidly increasing.
This is a fascinating pivot. Taking a device built for battlefield shrapnel and car crashes and applying it to entirely new fields of medicine. The literature specifically highlights severe postpartum hemorrhage.
Postpartum hemorrhage remains a massive driver of maternal mortality. If an obstetrician is facing massive, uncontrollable uterine bleeding, say, from placenta accrea or uterine atony, and the standard medical management is failing, the mother is bleeding to death on the table.
Historically, they might attempt to pack the uterus or rush to perform a massive, bloody emergency hysterectomy.
Right, but if a trained interventionalist or trauma surgeon can rapidly slide a 7 French Reboa catheter into the femoral artery and inflate it in zone 3,
You instantly isolate the pelvic vasculature.
the catastrophic uterine bleeding stops immediately. You stabilize the mother's hemodynamics, and you buy the obstetric team a calm, bloodless field to either perform the hysterectomy safely or to systematically ligate the uterine arteries and potentially save the uterus.
It is a profound crossover application of trauma technology. We are also seeing it used in massive gastrointestinal bleeding or hemorrhagic pancreatitis.
It proves that the physiological principle of proximal control is truly universal. If the pipes are leaking massively, shutting the main valve works, regardless of what caused the leak in the first place.
However, as with every powerful intervention in surgery, we must temper our enthusiasm with absolute clinical boundaries. The literature we review today is very explicit about when Reboa is the absolutely wrong choice.
We must outline the hard contraindications. That's a crucial caveat.
We already discussed the primary one. Supradiaphragmatic hemorrhage. If they are bleeding in the chest or the neck, Reboa is contraindicated because you will blow the injury wide open with the increased pressure. What are the other hard stops?
The second major contraindication is related to vascular access. There are specific traumatic mechanisms: massive pelvic crush injuries, bilateral proximal femur fractures, severe perineal avulsions where the femoral vessels are physically destroyed or completely inaccessible.
So you can't get the sheath in.
Right. If you cannot rapidly and safely achieve percutaneous access to the common femoral artery, you cannot waste time digging around in a hematoma. You must abandon Reboa and move to an open procedure.
The third contraindication deals with the patient's baseline physiology. Severe diffuse atherosclerosis.
This is critical in the geriatric trauma population. If an 80-year-old patient has aortoiliac occlusive disease, their aorta is lined with brittle, calcified plaques.
If you put a wire up there.
If you blindly force a catheter and a wire up that diseased vessel, you run a massive risk of dislodging a plaque and causing an embolic stroke, or physically dissecting and tearing the fragile aortic wall. The risk of iatrogenic catastrophe far outweighs the potential benefit.
And the final contraindication is cardiac arrest requiring open massage.
If the patient arrives in traumatic cardiac arrest or arrest shortly after arrival, and you suspect an empty heart that requires physical manipulation or internal defibrillation, you must open the chest.
A balloon in the aorta does not restart a fibrillating heart.
Exactly. Reboa does not replace the resuscitative thoracotomy, it simply narrows its indications. They remain distinct tools for distinct physiological emergencies. They are not mutually exclusive.
That distinction is the hallmark of a mature trauma system. Knowing exactly which tool to pull from the armamentarium in a fraction of a second.
Absolutely.
We've covered a massive amount of surgical physiology today. We started with the grim reality of preventable hemorrhagic mortality. We analyzed the historical failures of Hughes in the 1950s due to inadequate engineering, and we visualized the hemodynamics of aortic occlusion using that municipal hydraulic grid analogy.
We meticulously mapped the aortic superhighway, defining the life-saving potential of zones 1 and 3, and detailing the catastrophic visceral destruction associated with zone 2 deployment.
We highlighted the absolute necessity of radiographic confirmation and the role of the FAST exam in ruling out thoracic injury. We tracked the engineering leap from the highly morbid 12 French systems requiring open cut-downs to the percutaneous 7 French Reboa,
while also acknowledging the new biomechanical challenges of distal migration under systolic shear stress.
Right. We dove deep into the cellular pathology of the 60-minute ticking clock, the devastating cascade of anaerobic metabolism, lactic acidosis, and the lethal threat of reperfusion washout syndrome.
We examined the pragmatic institutional champion training model to overcome the implementation bottleneck.
And we aggressively dissected the conflicting clinical data. We weighed the early optimistic survival rates from Moore and Dubose against the sobering increased mortality and complication rates reported in the massive Joseph TQIP analysis,
identifying how selection bias and the limitations of retrospective databases skew our understanding of this salvage intervention.
Finally, we looked over the horizon at the promise of computerized partial inflation pre-BOA to cheat the ischemic clock, its expanding role in non-traumatic hemorrhage like obstetrics, and reaffirm the absolute contraindications that require us to still rely on the open scalpel.
It's been quite the journey.
It is a remarkable evolution of a critical care technology. But before we wrap up this session, I want to leave you with a final, slightly philosophical concept to consider the next time you are standing at the bedside managing profound shock.
Give it to us.
When you deploy a Reboa, you are fundamentally deploying a technological pause button on death. You are artificially halting the mechanics of exsanguination. But human biology utterly abhors a pause.
It really does.
When you pause the bleeding, you rapidly accelerate the machinery of ischemia and cellular necrosis. You are trading a macrovascular failure for a microcellular failure.
Which leads to a really provocative thought.
Yeah.
As our endovascular engineering becomes increasingly precise as we move toward automated, closed-loop partial inflation systems that can artificially hold the hemodynamics in a perfect stasis, how do we advance our cellular biology to survive the consequences of that pause?
Exactly. If we can successfully suspend a patient on the absolute edge of the physiological knife for 2 or 3 hours using computer-titrated balloons, what novel pharmacological interventions or cellular resuscitations will we need to invent so that the tissues don't forget how to heal once the balloon finally comes down?
When we master partial inflation, will we have unlocked a way to cheat the 60-minute clock entirely? It's something to think about.
Thank you for joining us on The Critical Edge. Keep scrutinizing the data, keep challenging the algorithms, and always maintain a profound respect for the fragile, complex mechanics of the human body. We will catch you on the next deep dive.